Is my screen visible to everyone?
Screen is visible, sir. You can just make it a full screen and click that got it button.
Yeah. I already made it full screen. Is it okay? Shall I start my presentation?
Sir, you can start.
Yeah. Good evening, everyone. So I have prepared my presentation as 6 cases. First one is a uterine fibroid. I was working in AIIMS Nagpur, yeah, where we were sharing cath lab with the cardiologist, and we don't have GA facility, so could not do more neurointervention cases. So I'll be starting with the uterine fibroid embolization with specific emphasis on the pain management, which is especially important with the fibroid embolization. My second case will be hepatobiliary case with which is a portal vein embolization, and the third, fourth, and fifth will be neuroimaging cases, and sixth one will be a neurointervention. I was doing only stroke thrombectomy and carotid artery stenting, as it can be done under monitor anesthesia, carry MAC. So only those two cases were being done. So all these 6 cases I'll be presenting for today. So first case is a 37-year-old female presented with symptoms related to multiple fibroids. She completed her family. She had menorrhagia with irregular bleeding, with severe cramps, especially during her menstrual period. And the ultrasound revealed multiple uterine fibroids, and the MRI was done. And MRI revealed there are multiple intramural and submucosal fibroids. Most of the fibroids were intramural in location. This was the largest fibroid with multiple flow voids noted going to the multiple flow voids noted feeding the fibroids. And in the arterial phase also there was homogeneous enhancement, mild homogeneous enhancement noted in all the lesions. Bilateral ovaries were normal, and the rest of the pelvic structures appeared unremarkable. So after the MRI, she was referred to us for the uterine fibroid embolization. So after planning embolization, pre-procedurally, since fibroid embolization carries a lot of uh, post-operative pain, post-procedural pain, we have started preemptive analgesia with the IV ketorolac 10 milligram intravenously, and also IV ondansetron Nemisat was started 4 milligram. Foley catheter placement was done so that pelvic structures during angiogram will be better visible. So during procedure, only local anesthesia was given for the vascular sheath placement. After that, a small minor plexus block was given during fluoroscopically, which is the superior hypogastric plexus block. This is done in order to relieve the, in order to reduce the pain post procedurally, and sometimes pain perception will be still present, but it will be much less as compared to those patients who undergo embolization without the plexus blockade. So in that idea, superior hypogastric plexus blockade was done. So the blockade was first initially yeah, 7 French sheath, 6 French sheath was placed in the right common femoral artery, following which a catheter was taken across the aortic bifurcation into the opposite side. So this catheter serves as a marker for the aortic bifurcation. The aorta is divided into the iliac arteries at this point, so that we don't inadvertently we don't puncture the arteries. And usually this aortic bifurcation lies at the level of the L4 vertebral body, which is seen here. And the venous bifurcation will be slightly towards the right side and inferiorly, around at the level of the L5 vertebral body. At around this point, we'll find the venous bifurcation, which is the IVC dividing into the iliac veins, or iliac veins joining the IVC at this point. So we select L5 vertebral body as this in the L5 vertebral body in the mid to slightly inferior level. You can see the Chiba needle is placed at the inferior aspect of the L5 vertebral body, so that this position is relatively devoid of the vessels, both arteries and veins, and inferior, but still it will be in the upper aspect of the L5 vertebral body. So we are choosing the inferior aspect, and the 22 gauge Chiba needle was just placed perpendicularly from Yeah, hello. So 22 gauge Chiba needle was placed perpendicularly from the was inserted perpendicularly from the skin surface into the vertebral body, L5 vertebral body. Usually, there is no risk of much. There is no major risk of injury to bowel with the 22 gauge Chiba needle, as the Chiba needle will be of very thin caliber. So usually, risk of injury to bowel loops are very less likely with this particular needle. So that's why without any guidance, only under fluoroscopic guidance, we can puncture the with a 22 gauge Chiba needle up to vertebral body. So once we hit the vertebral body, it can be confirmed both in the AP and the lateral planes, and slowly we can aspirate for any blood, because it should not puncture any of the vessels, and then slowly we can give contrast. So contrast will form nice triangular opacification like this. Opacification. Usually when there is some vascular opacification, we will see a linear structure from this extraperitoneal contrast going. So once after confirming that there is no vessels noted in the way, then we will be uh, giving 20 ml of 2% bupivacaine. Sorry, 20 ml of 0.5% bupivacaine will be injected through the same Chiba needle. While injection of the bupivacaine will be giving a slight forward thrust to the needle, so that it doesn't retract and go into any particular vessels. So with this, this procedure is completed. So this procedure takes hardly about 5 to 7 minutes, but it really works, especially in the post-procedure period, to relieve the pain for the patient. So this was the first thing done. Then subsequently, the with the 5 French Cobra C1 catheter, both ipsilateral and the contralateral uterine arteries were cannulated. Cobra and the prograde micro catheter cannulated, and we can see the tortuous feeders noted on both the sides. Then subsequently, both the uterine arteries were embolized in a standard fashion using the PVA particles. And after embolization, post embolization, there is a near complete uh, near complete blockage of the vessels noted, and there was no tortuous feeders noted in the post embolization period. So post-procedure, patient developed a moderate cramps, but however, the pain was lesser, especially when compared to those embolization performed without this plexus block. Then subsequently, in the post-procedure period also, we continued IV ketorolac 10 mg every 6 hourly for 24 hours. One patient, even despite plexus blockade and IV ketorolac, patient also had a slightly more pain. So we gave IV fentanyl bolus dose was also given. So all these were given. They're taking the anesthesia support, anesthetist support. Especially the anesthetist opinion was sought even before the procedure started, and IV fentanyl bolus dose was given. But opioid infusion was not required in this patient. Usually, for some patients, especially after fibroid embolization, may require opioid infusion for pain. So here only bolus dose was given, one dose was given, not more than one dose was given. That too only fentanyl was given. No requirement for any morphine or any high grade opioid infusion was not required. Then after about 24 hours pain, the moderate pain also subsided, and patient was discharged after about 1 day observation. So pain management in uterine fibroid embolization, we can see that uterine fibroid embolization is highly effective, and it is a minimally invasive therapy for fibroids, especially if on imaging wise, if it is feasible for embolization, then it's a highly effective therapy. But high incidence of post embolization syndrome is noted with the fibroid embolization, especially with the fibroid. It is due to the ischemia of uterus, which depletes the ATP, and because of depletion of ATP, there will be anaerobic glycolysis and lactic acidosis formation. This acidosis results in the pain. So usually the pain will be severe in the first 2 to 3 hours, and it reaches a plateau over 8 to 12 hours, and then it subsides. Over after about 24 hours, pain subsides. So during procedure, usually there will not be any pain. It's only the post procedure, after the procedure, pain starts. So this is the schematic diagram of you can see the plexus. So here this will be the superior hypogastric plexus at the level of the L4 L5 vertebral junction. So we can see this is the normal artery arterial bifurcation, that is aortic bifurcation. We can see at the level of the L4, this bifurcation will be there. So these are variants. The image B and the image D tells the variant. This is a low bifurcating variant and this is a high bifurcating variant. But usually, normally at the level of L4 vertebral body, we see the bifurcation, and the veins will be slightly, the iliac veins will be joining the IVC at slightly lower level at L5 and to the right side of the L5 vertebral body. So we'll be choosing this particular L5 vertebral body will be divided into 4 quadrants, and we'll be choosing this either right inferior or left inferior. Most likely we'll be going for the inferior central quadrant. To this area we'll be targeting so that there will not be any vessels. So this particular article is very good for the superior hypogastric nerve plexus blockade for pain control after uterine fibroid embolization. So this is about the first case of uterine fibroid embolization. So if any doubt, we can discuss it at the end also. Case 2 is about hepatobiliary intervention. A 58-year-old gentleman presented with right lobe liver lesion. Biopsy turned out to be a intrahepatic mass-forming cholangiocarcinoma. So the surgeon planned for right hepatectomy. So since the left lobe liver volume was inadequate, following liver resection, left lobe volume should be adequate to maintain the liver functions. So if it is inadequate, sometimes patient can go in for acute liver failure. So in view of left lobe liver insufficiency or left lobe low volume, patient was referred for right portal venous embolization. So this is the right portal. So we have placed first we took a 22 gauge cheaper needle, like how we puncture for the PTBD bile duct puncture. We took the puncture of we took a selective puncture of the right anterior segment portal vein using a 22 gauge cheaper needle. Then following right anterior portal venous puncture, we under ultrasound guidance and under local anesthesia. Even sedation was not given. So then subsequently microwire was passed into the main portal vein, and after passing microwire, we placed a 5 French sheet into the right anterior portal vein. Then we took a pigtail catheter. Since we don't have power, we didn't have power injector during that time. We just took a pigtail run from the hand. So that pigtail injection was depicted here, which is showing right anterior portal branch and right posterior portal branch, which is smaller in size because the tumor was completely encircling the posterior portal branch, but still left lobe liver volume was inadequate, and here we can see the left sided portal vein branches were seen here. So after taking a pigtail run, we took a thermo wire and then we took a reverse curve catheter, which is a SIM1 catheter. Since we have taken puncture from the ipsilateral, that is from the right side, because we were planning for right portal vein embolization, and we took a puncture also on the right side, same side, ipsilateral side. So we needed a reverse curve catheter to hook the right same sided branches, and then so we took a SIM1 catheter, and after taking SIM1 catheter, we took a prograde catheter and selectively cannulated the segments 5, 6, 7, and 8 branches. So after selective cannulation of all these branches, this is a segment 8 branch that we have selectively cannulated. We took a injection here. Then each branch, we usually the embolizing agent of choice will be glue and lipiodol in portal vein embolization, because while embolizing 5, 6, 7, 8, lot of branches, PVA particles usually there will be a lot of consumption of PVA particles, while glue and lipiodol can complete the procedure fastly also and effectively with less amount of with lesser cost as well. But since in this patient, we had PVA particles with ourselves, but lipidol was not available, and patient was also not affordable as they don't have other insurance, and other packages were not there. So since it was not available at that point of time, we have used only the PVA particles to completely embolize the portal venous branches. And then after So we used we can selectively cannulated one branch after branch, and then we injected PVA particles. About 3 to 4 vials of PVA particles were used up to completely embolize all these branches. And then while coming out, the posterior branch was very small, and it was just hardly feeding. It was completely compressed by the tumor, and there was no significant supply noted from the posterior branch. So this anterior branch, after embolizing, we have placed a interlocking coil as well. Uh, and post embolization, there was no stasis was obtained, and there was no significant hepatic parenchymal blush was also not seen, and we stopped the procedure. And then from the SIM injection, the SIM catheter, we took injection, last final injection, just to document the main portal vein and left portal vein patency. So both main and left portal veins were patent in the check angiograms. So this is the simple portal vein embolization. We have not done any segment 4 embolization. So that we'll be discussing later. So hardware used were 22 gauge CPAP needle, NEP set or micropuncture set, or any micro wire for that matter, which passes through the CPAP needle. Then subsequently over the wire, we place a 5 French vascular sheet. And then after placing a vascular sheet, a pigtail catheter, pigtail run will be taken initially, better with a power injector of 15 ml contrast at 5 ml per second or 7.5 ml per second. We can take a power injector run. Following the run, so that we will be knowing all the branches, variants, and everything. So after that, we'll be placing a SIM catheter over a thermo wire, and especially for the ipsilateral embolization. If it is from contralateral side, then we can use any normal catheters like vertebral, or the reverse curve catheter may not be required. And then subsequently, each branches may be selectively cannulated using pro-grade microcatheter, and then PVA particles or glue with lipidol and dextrose combination can be given. Glue with lipidol, I feel about 5 cases we have done. So in that 5 cases, I personally feel glue and lipidol has got a better efficacy, and also it has got relatively the procedure time is also short, so that radiation dose all tends to be lower with the glue and lipidol combination. So this the case that I have shown is from a different patient, whereas this is from a different patient. So prerequisites for portal vein embolization is it is done when liver resection is planned and the contralateral lobe is smaller in size. So usually we calculate this future liver remnant. That is the right lobe when it is being planned to be resected. The left lobe will be the future liver remnant. So future liver remnant should be adequate to compensate, because liver enlargement, liver hypertrophy takes time. It takes about 1 month or 2 months. So during that period, till hypertrophy happens, there should be an adequate future liver remnant. So this is calculated, especially when right hepatectomy is planned. Future liver remnant is calculated as the left lobe volume divided by total liver volume into 100. And the future liver remnant for the normal liver is 25%. But for cirrhotic liver, it is slightly on the higher side. It should be 40%. So if it is not 20, if there is no liver left lobe volume, if the left lobe volume is less than 25% for normal liver or less than 40% for cirrhotic liver, then portal vein embolization, right portal vein embolization to be specific, can be done. So this is in a patient, we can see that total liver volume was calculated like this using Singovia software. So this pink area denotes the right lobe liver, and the green area denotes the left lobe liver. This is a PTPT catheter placed for the pictal catheter placed for the biliary drainage. So the total liver volume was 1600 cc in this, whereas left lobe volume is only 520 cc. So FLR is only 30%, 520 divided by 1600. However, it is more than 25%, but the surgical gastroenterologist wished that portal vein embolization may be required for this patient. So the embolization images, I did not have the embolization images right now, but this is the pre-image where we can see that this is the right lobe liver and this is the left lobe liver. So left lobe liver is relatively smaller in size when compared to the right lobe liver. That's what we calculated here was 30%. And the post embolization, you can see right lobe is shrunken when compared to this. Here there is a definite shrinkage of the right lobe, and left lobe has significantly enlarged. So from 30%, post embolization it became 50%, 50, which is definitely quite a significant hypertrophy, and more than even 40%, which is actually the cutoff for the cirrhotic liver. And we can see here that left lobe liver is ending with the at the level of the stomach, whereas here we can see this is the stomach. So left lobe liver is just engulfing the stomach, completely surrounding the stomach. So that much of enlargement has happened, and this is the image post procedure after a 1 month follow-up. This is actually for 1 month follow-up. So during the period of 1 month, when liver is tending to regenerate, during that time usually they give chemotherapy so that the tumor does not uh, I mean, the metastasis risk is still there, so that's why they start chemotherapy during the 1 month wait period. And chemotherapy tends to slightly reduce the liver hypertrophy. That risk is there. I mean, the risk of lesser hypertrophy is there when chemotherapy is concurrently being given, but we don't have option, especially since there is no definitive management for the patient. The chemotherapy will be started during that 1 month wait period. So techniques of portal embolization, there are two techniques, which is ipsilateral versus contralateral. In our limited experience, we have done all cases with only ipsilateral side. So contralateral was not done in our experience. In typical right portal embolization, segments 5 to 8 is segment 5 to 8 are embolized. In extended right portal embolization, especially when they want to do a extended right hepatectomy. That is, even they will be planning to resect segment 4 as well. Segment 4, 5, 6, 7, 8, all segments they tend to uh, resect. During that time, segment 4 is additionally embolized. So when segment 4 is additionally embolized, especially in ipsilateral portal vein embolization, we have to first embolize segment 4, because segment 4 usually branch usually arises from the left portal vein branch. So that when we use a SIM reverse curve catheter, we can't cannulate the segment 4 branch as it is arising from the left portal vein. So in that case, if we don't embolize segment 4 first, when we embolize all other segments, that is 5 to 8, then there will be a thrombus formation in the right portal vein. Now, if we remove SIM and then if we introduce another catheter, there is a theoretical risk of thrombus dislodgement into the left portal vein and main portal vein, which we do not want. So that is why always it is told during ipsilateral portal vein embolization, segment first is to be first embolized and then followed by embolization of other branches. So segment 4 can be cannulated by any normal catheter like vertebral catheter or multipurpose catheter to be embolized first, and then followed by a reverse curve catheter can be taken, and segment 5 to 8 can be embolized. So left lobe hypertrophy may be less in patients with diabetes and when concurrent chemotherapy is being given, especially after the portal vein embolism during 1 month wait period. So now coming to the third case. Third case is about an 8-year-old boy who presented with short stature. He was identified as growth hormone deficient and was started on growth hormone supplementation. MRI brain was done for the same. So these are the MRI images, T1 MRI images. So can anyone can describe the finding? Basically, the history is short stature, growth hormone deficiency. Can any resident, if available, can they describe the findings, or shall I describe it? So with the short stature and growth hormone, you can think about the pathology being located.
The pituitary appears small.
Yeah,
No
correct.
bright spot
Pituitary
is
is small.
visible.
Yeah, no bright spot. Can you find out the bright spot where it is? This is AC. Okay, AC is seen in one hyperintensity. So this is the vessels are seen here. So you can see this is the posterior pituitary bright spot is here between the optic chiasm and the tuber cinereum. At the tuber cinereum, you can see the posterior pituitary. So it's a ectopic posterior pituitary with a smaller cella. Any other finding is there apart from these two? Because when you see optic chiasma and tuber cinereum, anterior and posterior, what is the structure you'll be seeing here? Infundibular stalk will be seen. No, so stalk is not seen in this patient, or it's very thin. I don't know whether this structure is stalk or not. So basically, stalk is infundibular stalk is not well appreciated in this. So putting to all these findings together, can any I think only these three images are there. So have you heard of any diagnosis putting all these findings together? So here, this coronal image also denotes the ectopic posterior pituitary bright spot. So basically, this is a pituitary stalk interruption syndrome, PSIS. So there, usually they will have absent or hypoplastic pituitary, usually less than 3 millimeter in size, the total height of pituitary. Here also we can see that there is some tissue seen just draping the cella, but no definite pituitary gland is seen. And the ectopic posterior pituitary bright spot and absent or hypoplastic stalk. So usual this ectopic posterior pituitary location will be located in the tuber cinereum or in the infundibular recess. So it's it can be only confirmed radiologically, pituitary stalk interruption syndrome, and using based upon the laboratory features. Coming to the fourth case. A 27-year-old male patient presented with hypocortisolemia. So lower cortisol levels, and because of the low cortisol levels, he developed electrolyte imbalance such as hyponatremia, and it was corrected, and he was treated symptomatically only. No surgical resection was done for anything, and no treatment like cabergoline, dopamine antagonist like cabergoline or bromocriptine was not given. So only it was corrected, like for hypocortisolemia, cortisol was given, glucocorticoid administration was done, and for hyponatremia, the resultant hyponatremia, sodium administration was given, and only symptomatic management was done. MRI was done twice. So this is the first MRI. So this is the first MRI where you can see the T1 image and the T2 image. So T1, it is non-contrast T1. So can you see what is the abnormality? Again, same cortisol. So something related to stella and pituitary. Can any resident tell like
This
finding?
uh, pituitary appear hyperintense on T1,
Yeah,
and
T1. How is it on?
craniocaudal length is increased.
Yeah, craniocaudal length is probably increased. And how it is in T2?
T2 it is appearing some central hyperintensities are there, surrounding hypointensities are there.
So predominantly here the lesion is hypointense, and there's some cleft-like thing seen, but definitely normal pituitary gland I'm not able to see. It is like hyperintense area inferiorly and some hypointensity is there. And the total lesion is also lesion also appears slightly, I mean, the gland as such appears enlarged with a lesion. So the lesion volume is about not 85, it's 0.85, 0.85 cc. So T1 hyperintensity with some T2 heterointensity, predominantly hypointensity. What are possible differential diagnoses?
Is there any gradient available? Gradient or
There was no blooming in gradient. Actually, SWA image I don't have, but SWA was done. There was no blooming in SWA. And this is the second MRI. In second MRI, these are both plain T1 images, T1 empirage and Spinnaco T1 sequence. So now what happened to the lesion? This again 0.44, not 44, 0.44 cc. What happened to the lesion?
well, its size is decreased after the treating.
Size is decreased. No, yeah, after symptomatic treatment only size is reduced. Now T1 hyperintense, what all you can think? Apart from one thing you told is blood, which is SW blooming is not there. So what are other things that could be hyperintense on T1?
Right. This all is protein,
Yeah,
melanin, and the
yeah,
pituitary granules.
correct, correct, very good. So fat suppress image was done. No fat suppression was there. Still, it was hyperintense in fat suppress image. So it was not the fat. So protein containing lesions, what all you can think in the cellular or supracellular region?
Rathke cleft cyst can be there, but Location is
Yeah,
not.
but what? Location is not. Why location is not?
No, I couldn't see as normal pituitary separately. So entire pituitary is
That,
increasing size, then followed by decreasing size.
yeah.
So
Yeah, when sometimes when this we don't know, I don't know exactly whether this is a normal pituitary tissue or not, but sometimes when the cyst is like enlarged, when cyst is like huge, sometimes pituitary gland could be compressed actually, which we may not be able to pick up. But even I was thinking that in the initial MRI, this might be a possible cleft with a normal pituitary, but we are not very sure. But from the evaluation of the, because there was no definitive treatment provided given to the patient, so only a symptomatic treatment provided given to the patient, and with this, since the lesion is reduced in size, we di our diagnosis, like it was initial MRI, from the initial MRI findings, it was given as pituitary adenoma, something like a Sheehan syndrome, with hemorrhagic pituitary adenoma was provided, and craniopharyngioma was provided outside. Then subsequently in the second MRI, when it came to us, then that time we, after analyzing all these findings, usually in Rathke's clefts, there will be intracystic mural nodule as well, T2 hypointense mural nodule as well. But that mural nodule is also not present actually in this, but the entire asset, there is a heterogeneous hypointensity is seen in T2. But we finally gave the possible diagnosis of Rathke's cleft cyst only based upon all these findings, and usually Rathke's clusters will be T1 hyperintense. It could be intracellular in location. But as you told, there can be a normal pituitary cleft can be seen, but in many cases, it may not be seen because of the compression effect by the cyst itself. And uh, it could be intracellular in location or supracellular in location, but predominantly it will be supracellular with intracellular extension. And the T2, it will be hypointense, and the intracystic T2 hypointense nodule is very characteristic. And the spontaneous regression or spontaneous reduction in size without any definitive therapy is also possible, especially possible after glucocorticoid therapy, because this patient also had hypopituitarism. So there are multiple reports, literature, multiple reports telling that the clinical features usually will be hypopituitarism, like in our case with the Rathke's cleft cyst. Many times it will be asymptomatic, and whenever it has it manifests as hypopituitarism. And there are case reports also which shows the spontaneous regression of the Rathke's cleft cyst. So one possible explanation they're telling that for spontaneous regression is the possible glucocorticoid therapy. And in some cases, even without any therapy, even without glucocorticoid therapy, there are reports mentioning about regression of the Rathke's cleft cyst. And surgical excision has to be done, especially if symptoms persist or increase. So in our case, till now, surgery was not done for the patient as it is reducing size, and patient is also symptomatically very much improved. With only glucocorticoid therapy, he has significantly improved. So that's why surgical excision was deferred at that point of time. So case 5 is about a 29-year-old female who presented with headache, dizziness, and recurrent blackouts. On leading history, on probing, she mentioned a facial patch was present during childhood and it was treated. But the treatment details was not available. At present, she's a dark female and we could not make out any patch in the face. MRI was done. So can you describe the findings here? Presented with headache, dizziness, and recurrent blackouts.
Left cerebral hemisphere appears dysplastic.
Okay, good.
And globe,
Dysplastic or
globe is enlarged on the left side. Carpus
correct.
callosum is not
So
properly formed, the anterior part.
exactly correct.
Uh,
And
Vermis is
here in
also,
this T2 can
yeah, T2.
okay, vermis is also dysplastic. In this T2 image, could you identify something or could you see for something especially uh, around this area, around the clivus or
Left Meckel's
so?
cave, right. There
It,
is some asymmetry between bilateral Meckel's caves.
okay,
That's not finding.
what is this? What is this flow wide?
It is ICM.
ICA fibroid. And can you find it on left side?
Oh, that's fibroid is not seen on left side.
Left side is not
I,
seen. So this
I
patient initially
it was
angio was not done, but with this finding we asked her to do a TOF angio. So putting all these findings together in the plane itself, can you arrive at something? Like you told enlarged globe could be a posterior staphyloma
yes.
with cerebellar hypoplasia or dysplasia with corpus callosum dysgenesis, especially in the anterior aspect, and absent to fibroid on the left side. So is there any correlation for all these things? And on leading history, there was a facial patch, but at present we could not make out. And she herself is a dark female, so we could not appreciate any this thing, discoloration also.
Yes.
Yes, sir. Hello.
So, yes. Um, there any other anomalies
Okay.
in the body or only isolated brains?
Only isolated brain. There was no other anomaly in the body, especially all other things. When she came to us, nothing, no significant abnormalities were present. She came only for the recurrent blackouts. So that could be explained due to this left eye view. So you can confirm, we have done, then after these findings we made out in plain, then we did a angio where also it was confirmed that in which also it was confirmed that left ICA is completely hypoplastic or aplastic or occluded. So as of now, then we did the CT also. CT in the CT image I don't have. CT there was no. Hello, am I
Yeah,
audible?
you
Hello.
are audible. Yeah, yes, sir.
Yeah. So in the CT, there was no hypoplastic or a very small carotid canal. Carotid canal is also not seen in the CT. So which also this thing confirms that it's not a occlusion, it is a hypoplasia or aplasia of the left eye. So putting all these findings, we gave possible diagnosis of PHACE syndrome because PHACE syndrome stands for PHACE syndrome stands for. Can you just
Uh, po-
expand PHACE syndrome?
posterior fossa anomalies, heart defects.
Yes,
Um,
it's hemangioma. H.
oh, sorry,
H is hemangioma. Yeah.
hemangioma,
And A is arterial anomalies. Arterial anomalies. C is coloboma. Uh,
cardiac and
C
eye
is
anomalies.
cardiac and eye anomalies. E for eye anomalies. And S is there. That is sternal cleft or sternal anomalies. So it's actually phases syndrome. So in this syndrome, there is major criteria and minor criteria. Major criteria for arterial anomalies include the hypoplasia, dysplasia, or anomaly of major cerebral or cervical arteries. So in our case, there was hypoplasia of the large cerebral, that is ICA or cervical arteries. This is ICA is hypoplastic. So that was a major criteria. And structural brain criteria, brain anomalies were posterior fossa brain anomalies, and that was also present in our case. And the ocular, there was this thing, staphyloma-like finding, peripapillary staphyloma was present. So that's again a major finding. Sternum we did not examine actually. Even angio also after plain was done initially without angio. So after seeing all these findings only we have done the angiogram. So because of that we couldn't clinically examine the patient. And hemangioma is plus minus. But that is a very important feature. But since he presented as an adult, we could not. But she definitely gave on asking. She definitely gave a history of hemangioma in the. I mean, a history of some pigmentation disorder in the face in childhood, and for which she has undergone treatment. But the treatment details are not available. So, despite not having, in case if we take that hemangioma is negative, then also we have no hemangioma plus two major criteria. We have three major criteria. So that is why we diagnosed it as possible PHACE syndrome. So this was our, and if there is hemangioma, usually the hemangioma will be in the segmental distribution, that is along the ophthalmic, maxillary, or mandibular. In the fifth nerve distribution, it will be there. So a large segmental hemangioma that is corresponding to the dermatome V1, V2, or V3 dermatome, if present, then one minor criteria itself is sufficient. The aneurysm, these are the minor criteria. So So any one minor criteria, if it is present, then that is sufficient. If hemangioma is not present in the face, that is along the trigeminal nerve distribution, if it is present in the neck, upper trunk or trunk and proximal upper extremity, then one major or two minor criteria will be sufficient to tell us possible phase syndrome. And if without hemangioma, two major criteria is required. Already three major criteria are satisfied in this particular patient. If for definitive phase syndrome, there should be a segmental hemangioma, as I told, in the face or head, plus one major or two minor criteria. Or if hemangioma is present in other areas other than the face, then two major criteria is required for definitely confirming it is a phase syndrome. And the sixth case Sixth case is a neurointervention. A 55-year-old gentleman presented with unresponsiveness, inability to move all the limbs. Patient presented to ER. Patient had vascular risk factors, diabetes, hypertension, and he is also chronic smoker. Patient presented to emergency room 6 hours after the onset of the symptoms. On examination, NHS score was 25 and patient was unresponsive. So MRI with MR angiogram revealed the basilar top occlusion with no antegrade flow, and MR diffusion aspect was 6 with pontine involvement which scores 2, and bilateral occipital lobe which each one scores 1. So 10 minus 4 is 6, and MRI images at present is not available. So with 6 hours uh, symptom 6 hours from symptom onset with NHS of 25 and MR diffusion aspect score of 6, we took the patient up for thrombectomy. Hardware was used as neuron max long sheet was used. Then through that, we used the A68 aspiration catheter, large bore aspiration catheter, and a trivocentrifuge over a rebar 27 micro catheter was used. Solumbra technique was done basically with both aspiration and the stent retriever, using both aspiration and stent retriever. So this was the top of basilar occlusion. So after first pass of the stent retriever, so this was the A68 catheter which was placed close to the clot with the stent retriever deployed from the initially stent retriever deployed from the right P1 to basilar, and after first pass there was some opening of the right P1. However, filling defects was still noted and left P1 was not adequately opened. Then we made a second pass, and after second pass of Solumbra, there was complete opening of the basilar and bilateral PCA was noted. So patient improved after significant ICU stay. Patient had quite a stormy ICU stay because posterior circulation stroke usually have a guarded prognosis and slightly worse prognosis when compared to anterior circulation stroke. But however, patient was discharged after a significant ICU stay, and there was some residual neurological deficit during the time of discharge. And MRS score was 2 at the time of discharge, and after that I don't have a follow-up at present. So I thank everyone, especially the Sri Chitra Alumni Forum and all faculties, all my mentors from Sri Chitra, and all seniors from the various institutes where I worked till now, seniors and my colleagues.